Dr. Neighbor.
Thank you. Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We're so happy that you have chosen to join us. We have no dearth of topics to discuss regarding COVID. You would have thought at this point we wouldn't have so much, but it just keeps on giving. So thanks for being with us, and plan to have your mind stimulated and maybe even your emotions stimulated by some of the things that we are going to talk about. Hopefully I've teased your interest. And without further ado, I turn it over to Dr. Maxer.
Thank you, Dr. Neighbor. We appreciate you every week as we do Dr. Ivan Walks and Dr. Jocelyn Hines. And we have a special guest this morning that we're going to continue to talk about this problem with COVID-19 and all the subsequent variants. I would have thought by now, Dr. Walks, that we'd be turning the corner and talking about diabetes and schizophrenia and everything else, but looks like we keep getting pulled back down into the pit, talking about COVID-19 rising again and keeping our community safe. So our special guest and discussant that we'll have questions for and join is Dr. Despani, Dr. Jordan Despani. Dr. Jordan Despani has a PhD in pharmaceutical science. He considers himself an entrepreneur, and I know we're talking to people like Goldman Sachs and things like that, but he's also a virologist and has done studies in HER2 negative cancer, and he has been appointed the director of science for the Black Health Trust. And we always enjoy when he's here to put us on the right track and help us understand these viruses. So welcome, Dr. Despani. So he's not going to give a lecture, but we're going to show a few slides and have him give some inside information. And let me just show the first slide, Simon. So what we do know is that COVID-19 is still associated with hospitalization, even among those who are vaccinated. But we understand that those who are vaccinated tend to have less hospitalizations and less death and destruction when they are there. But starting from there, let me give the floor to Dr. Despani, and we'll have questions for him, and we have some slides we can discuss going on. In fact, let's see the second slide. In January, and this is out of the New England Journal, most recent version, in January of 2022, unvaccinated adults, and those who had had a previous infection, primary infection with COVID, were 12 and 3 times more likely to be hospitalized, respectively. And those who received a booster or additional doses did better, but the increases in hospitalization were still greater among those of Black race and ethnic background. So with that, Dr. Despani, we'd love to hear some of your opinions. And don't talk about my spelling.
Yes. So, yeah, one of the most important things to consider is the fact that, and the topic that was actually discussed in one of the earlier Black Health Trust series, is that there's this risk of syndemic, wherein person not only has to worry about the risk inherent in SARS coronavirus 2, but also must deal with comorbidities such as cardiovascular diseases, diabetes, etc. So that is most likely a very large factor in the case that when Blacks and minorities get, the infected, they tend to bear the brunt of all of these untoward, like additional, like downstream effects. And then second aspect that's more focused on the sociological aspect is just when a person from, like one of these underrepresented backgrounds and when that actually does get sick, they don't necessarily have like the ability to go to a hospital that has, the best of care, so forth and so on. And this is something that, again, can't solely be solved only through a medical context, because you have to consider that, medicine, society are interwoven. So yeah, those are two of the biggest factors that lead to like this disproportionate impact on minority communities.
So my concern is that a lot of people now think they're free and we can do anything we want. They're getting rid of the mask mandates. And I know Dr. Neighbor is going to talk about the fact that the government is taking away finance from the vaccine program. So what is our message still to communities of color about the validity of the infectivity and toxicity of this drink? Can we do anything we want now?
Most certainly, like not. I mean, like one thing that I have taken to considering the this pandemic and whatnot, as somebody who actually ended up getting the BA.1 Omicron variant, which had knocked me out for a good part of the beginning of this year, is that you need to be able to adapt in real time, meaning that you need to consider your risk matrix within the context of everything around you within your community. So one way that we can look at this pandemic now is within the context of like maybe more of a weather report. And this is something that many organizations like the CDC have also taken towards, where it's like in your community, like what's the threat level or risk perception in order to steal, a term from the, military, right? Where in some areas, right, it could be, safer, but the reality is that you also have to look at your own individual risk, right? Is this same, reality as like the fact that, again, you are responsible for taking care of your own health at the end of the day. Because again, like while things might be safe for most people, imagine if you were talking about a patient who actually has immunodeficiency, right? Like they really have to take good care of themselves. And on top of that, one also must be cognizant of the fact that, again, like the therapeutic landscape is changing. Case in point, there was an antibody therapeutic called sotrovimab, and that actually worked against many of the prior variants. But now that we're on BA.2 Omicron, it just is not able to work against the point mutations in the BA.2 variant. And then the other point that I wanted to get across to the community is that the CDC is also CDC and FDA rather are both cognizant of the fact that, again, this threat matrix differs for different people, and they're actually on the verge, the FDA is on the verge of deciding sometime next week, most likely Tuesday, but since we're using standard deviations, let's say anytime next week between Monday and Friday, that they'll probably okay a second booster dose for those age 50 plus.
May I ask one more question before Dr. Neighbor and Dr. Walks and Dr. Hines come in? That is, there's some confusion, I believe, about the naming conventions. And maybe you can just give us a brief primer on, starting with Alpha, how these things are, how can we keep up with the names BA 1.1, et cetera?
Was that question directed to Dr. Stevens?
I'm sorry?
Who was that question directed towards?
You.
Okay. Yes. So for like elucidation, these names like BA1, BA2, BA3, BA4 are those are more technical determinations. And the reality is that in discussing it with the lay community, just generally, like the World Health Organization and other groups had decided that it would probably be best and most advantageous to move forward with a naming classification that was very easy. And that's kind of why we settled on the Greek alphabet, like alpha, beta, delta, and whatnot. The problem, though, is that it's very difficult to try to use the alphabet, the Greek alphabet, whenever there's actually all of these sub-variants and whatnot, because the reality is that BA2 belongs to the like Omicron, right? Then you can consider it like to be like a family of like, cousins, like relative to say Delta, which, is like completely different, but they're all related by the fact that they all are SARS coronavirus 2. But that's just even the best laid, man-made plan kind of buckles under the weight of like what evolution has to throw at us. And then also consider the fact that probably the next variant was actually not supposed to be called Omicron. It was supposed to be called Nu, like the Greek alphabet Nu. But then obviously that would confuse people because Nu is too similar to the English term new, N-E-W. So they skipped it. And then there actually was another Greek alphabet. Like I don't know how to pronounce that, but it was too similar to the name of the Chinese premier, Xi Jinping. So they just decided to skip that and go over to Omicron. And then now, right, we have some recombinants that are actually emerging, viral recombinants. So one that I told Dr. Kenneth Steiner, I'm not sure if Dr. Kenneth Steiner is on the call, but he had asked me for an update. And I told him that in addition to like this, BA2, there's also two viral recombinants. One viral recombinant is of BA1 and Delta. So that created a viral recombinant, like viral sex, for lack of a better term. But there are very few cases of that. And then there's also, I believe it's called BA4, and that's a recombinant of BA1 and BA2. So that's kind of why it's like, okay, so do we keep coming up with Greek letters for all of these sub variants and whatnot? So that's kind of why, like I said earlier, the best laid man-made plans kind of buckle under the weight of evolution.
Thank you. Dr. Neighbor?
Thank you. So, Dr. Despani, we are aware of the rising prevalence of, I think now I've gotten confused, but I think it's B2 in the United States, following behind the rest of the world. And there have been projections voiced of it following a similar pattern that it has followed in the rest of the world, so that it won't be necessarily as big a surge, but we should be anticipating in the next 4 weeks now, I guess, some degree of surge. But what I haven't seen, and I think, well, my suspicion is that a lot of information about other events going on are getting pushed over by the events in the Ukraine. So can you provide us any kind of insight as to what seems to be bubbling along in the world, not in the United States, but what's bubbling up in the rest of the world, if anything, right now in terms of variant activity has been picked up? And there's a very specific reason why I'm asking you this, because I'm going to be coming back later to some points about what's going on with US surveillance.
Yeah, I mean, as I said, there is the recombinants, right? That BA1 and BA2 creating BA4. That's strange, but not unexpected. And then there's also that the BA1 and Delta, which some have colloquially taken to calling Deltacron. So those have infected, I'd say, a handful of people, but there's something to kind of pay attention to on the technical side, but nothing that lay people should worry all that much about. But just always being cognizant of that. And then probably outside of the variants, the other thing I would say is that the upcoming decision by the FDA to consider a second booster shot is wholly influenced by the fact that Israel has some data concerning administering a second booster, aka a fourth shot, to those age 60 plus, and the reason why is because they need their systems boosted precisely because as you get older, your thymus grows smaller, and your thymus is what produces T cells and so forth and so on. So takes and your immune system naturally undergoes what's known as immunosenescence, aka your immune system is aging. So that's kind of why having these booster shots can kind of like juice up a waning response. Because one thing that we know for a fact with coronavirus is something that I even studied way back whenever I was around 2009, 2010, is that these they don't necessarily induce like this lasting, immunity that people are accustomed to with like measles, mumps, and rubella, right? Where you can just get like one shot and then it's all, like done. Because again, as I've said in prior programs, that this is an RNA virus, and RNA tends to be more mutagenic. And yeah, like this is more similar to influenza viruses, where you need to kind of get shots every year, as opposed to anything else that we've seen, because again, they're respiratory viruses and whatnot. One thing I will say is that Moderna did have it's like they have a very grandiose title, but it's called like World Vaccine Day, and that they kind of revealed like their latest pipeline. And one thing that they had on the table was a multivalent mRNA shot, which would cover the original Wuhan variant of SARS coronavirus 2, the BA1 Omicron variant, and then also some other aspect. But basically, they're taking a multivalent approach, and they're also trying to do it for influenza viruses as well. So very encouraging, but we have to see because we have to work with the tools that we have.
So what exactly do you mean by multivalent?
Multivalent basically means that you have multiple antigens that are present in a shot that allow your immune system to build up a response against multiple targets. Case in point, anytime you've had like probably since 2017 or 2018, any of the influenza shots you've gotten every year is multivalent. So before they were trivalent, meaning that they gave you protection against like two strains of influenza virus A and then one of influenza virus B. And then now we've gotten so good that we can give quadrivalent shots. So whenever you get the flu shot, it's not just, oh my God, you just got the flu shot, right? It's there's some fun science going on showing that things are moving forward. And yeah, I mean, that's kind of the way to go, because instead of like trying to get like a shot against one thing, you want to hit as many targets and have, quote unquote, to use a colloquialism, as many shots on goal as possible, so that again, if you don't hit that variant, but you get infected by another one, your body should be able to ramp up a rapid immune response. So it's basically, to steal a term from the U.S. military, you're trying to aim for a fire and forget scenario.
Dr. Maxim, may I ask one more follow-up question?
Of course,
because
sure.
I understand the rationale of additional boosters to stimulate your thymus and augment your immune response. I get that. The vaccine will be polyvalent perhaps or not. But what I don't understand is there any rationale to whether it's 2 boosters or 3 boosters if the variant strain is not included in the booster shot? Is there any advantage to getting the additional boosters? So for example, let's say one of the recombinant variants that you mentioned just now picks up steam and becomes a dominant form in August, and it's not included in this potential fourth dose, is what advantage would an individual over 65 have? if any?
You would still have some advantage. So the one analogy that I used in a prior program was that vaccines are tantamount to taking a snapshot of like a celebrity as they come out onto the gold carpet, or the red carpet for like the Oscars, which is apparently going to happen today. But the thing is that with a natural infection, on the other hand, it's kind of like you have like, I don't know, like NBC or like Sony Pictures and whatnot. They hired a whole paparazzi crew, and like they can take a 360-degree kaleidoscopic picture of the person. The problem though is that with a natural infection, you also run the risk of developing untoward things, like for instance long COVID, or your brain starting to like get smaller in brain volume, right? Which is I don't know about you, but I don't want that. So again, it's more often than not, like sometimes like the natural infection is unavoidable despite the best things that you can do, but you do want to try to arm your body so that it can be, go to the fight prepared, right? Like I don't think that the thriller in Manila would have been as thrilling had Muhammad Ali decided, I'm just not going to work. I'm not going to do anything. I'm just going to go in and hope for the best, right? No. So so then with that same mantra, right? You want to like at least have something in your body, even if it's not 100% perfectly like matched towards like one of these new like recombinants. Again, it's a relative or a descendant of the original SARS coronavirus 2. So the things that are changing are like those epitopes and the like these recognition things, like the spike protein, right? Like those are the mutagenic parts of the virion. And just so you know, a virion is a virus particle, right? But then there are other aspects of a virion, a virus particle, that don't really change, like your matrix protein, for instance. The matrix protein is what's responsible for actually like creating like the structure and stability of that virion. And then there's also the nucleocapsid and so forth and so on. So yeah, those things don't necessarily change as much. And that's actually why the US Army is working on a pan coronavirus vaccine that actually targets one of those, what we in the scientific community call highly conserved like regions of like say a virus or a pathogen or something like that. So, but yeah, I mean, your body is also doing that as well, because once you get infected or get the vaccination and whatnot, right? It's taking some aspect that is building a broad recognition system, because your immune system has to first start out building something that can like just broadly identify like, hey, that guy has a like, I don't know, like a blue shirt, like we need to look very askance at many people with blue shirts. And then afterwards, then you start to build in the granular details, like, oh, this blue shirt thing also has a spike coming out of its face. Okay, now we know that SARS coronavirus 2. So just so you know, yeah, I mean, it's still valid to have some type of protection, even if it's not like a 100% like, like, oh, okay, like we're going to come out with a new vaccine that perfectly covers this, because your immune system also works in that way, right? You start out broad and then you like kind of go through different layers of surveillance and whatnot. So that's the same way. So I mean, it's better to have some protection based off of a broad factor, like it's going to recognize SARS coronavirus 2. Then you go all the way down to like, okay, it's going to recognize this recombinant.
Got it.
Dr. Walks, got any thoughts?
Thank you, Dr. Maxey. So, Dr. Despani, I'm always excited to see you, and that I'm going to ask you to go back to what you said earlier. You said that that the COVID had knocked you down for a significant part of the first part of this year. And I think a lot of times I try to get to sort of the personal, because I'm guessing, we haven't talked about this in advance, and I'm sorry if I'm getting a little bit too personal, but my assumption is, based on what you say when you're here with us on the Black Health Trust, that you've had your shot and your booster and what have you, and yet you still got COVID to the point where you shared with us that it knocked you down. And so my question is, how has that, if any, changed your respect for COVID and the fact that it's important to do everything we can to be protected? How has your personal experience either changed or reinforced for you the advice that you give us?
As always, Dr. Waltz is always a blessing on this program because you provide the most human of touches in medicine from multiple aspects. Yeah, I mean, I will begin by saying that I actually thought that I was at fault because I was like, I've done everything right. I mean, I basically have cocooned myself off, with some exceptions, to go on business trips and whatnot to the world and whatnot. And this is something where, like again, I'm in not necessarily in Los Angeles right now or even New York, right? I'm like right, just smack dab in the middle of the country. So I'm like, okay, why got all of my shots, booster and whatnot, and I got infected. So yeah, so I mean, a lot of it was came to this horrible thing of like victim blaming or shaming and whatnot. And the reality is that then I had to lift myself out of that spot because the reality is that an infection at the end of the day is like it's stochastic, right? There are some people that have, despite all of the different variants that have come along in this roller coaster of a pandemic, there are people that have not been infected at all, and then the other people that do, get infected, and some people that get reinfected, right? Case in point, the data that I've seen indicates that there's like only in other parts of the world that some people who have had BA1, there's only like a 7 to 14%, more like on the 7% side, chance that they like get infected with BA2. So it's small, but it's non-zero basically. So yeah, I mean, that gave me the fact that I had developed it and suffered. The worst being that even when I thought I had recovered, I actually had these strange raccoon-like black eyes for too long, which might point to some cardiovascular thing. Is that it really taught me, the value, and it taught me to be more humble and also to understand like firsthand like what the people that you're helping and providing information on, like what they're actually going through, right? So that actually creates a like a bonding, if you will, with your work, because it's like, yeah, this is why I'm distilling all of this valuable, incredible insight to the Black Health Trust, because I don't want anybody to go through like what I had gone through. But then on the other end, you also see that I'm here before you, right? Like with back to normal, doing 3-mile runs, etc. So it's not that it's the most, damning thing if you ensure that you always protect yourself. Right. So it's I mean, it's a enlightening thing, but it's something that I don't want other people to go through. And the thing is that with the pandemic, it's a very it's a marathon, right? I mean, even the last pandemic of repute that like really has stricken America outside of the HIV-1 pandemic, which has been going on for 40 years now, the big one that cost lives left and right was the 1918 Spanish flu, and like that actually had about 3 or like people only really focus on like the beginning, but there technically were like 3 to 4 waves, but people had kind of like forgotten about it and it stopped appearing in the news, even though people were still dying. So we don't want to make the mistakes now, the 2020s that we made in like the late like 1910s. So yeah, I mean, just be mindful. Again, like no one is saying that you need to become a vagabond and whatnot, but you also need to be mindful of the risks, right? It's the same analogy that again, like to like a storm or like a weather system and whatnot. Like, okay, yeah, if it's saying that like your community, your area like is having like high transmission of like BA2 Omicron, be mindful. Case in point, like where I am, there's like high transmission, it's rising, but it's getting high. So and be mindful. I stay in, but it's all about like a person's individual like threat assessment and making sure that they're taking care of their own health.
So Dr. Despani, first of all, thank you for sharing your personal journey with us, and thank you for being with us as always. It's fabulous when you're able to be with us. One of the and I want to let Dr. Hines ask her questions, but I'm not going to stop with mine right now. One of the things that I struggle with now, like Dr. Maxey started off with, come on, it's March, and we thought we'd be on to other stuff, and we're still talking about coronavirus because it's still killing over 1,000 people a day, and it's still a big deal. And at the same time, it seems like we're checking less, right? The government is closing down the testing centers and all of that, and things are changing. And so I guess, and I'm asking you, it seems like we're knowing less about what's happening in our communities as people are testing at home and not necessarily reporting their results to the CDC. So how confident can we be when someone says the transmission is low or things are getting better when we're not checking as well as we did before?
Yes, that's actually one thing that has, stricken me, right? Because as you may or may not have leveraged, like the U.S. government was so kind as to send people complimentary packs of these. So I have one as a souvenir and also to leverage if something happens. But yeah, I mean, the reality is that it's tough if people are taking these, like get your results in 15 minutes, but then never report them types of things. It's like, yeah, it's difficult to draw more epidemiological data. So then you have to turn to more bespoke, for lack of a better term, methods of determining what's going on with community transmission. And one of those that can actually be leveraged would be wastewater treatment levels, right? Because if you look at wastewater, like that is actually a good source of many different like pathogens, and especially like viruses and what have you. And that actually tends to be a leading indicator, to steal a term from economics, to basically figure out like if there's going to be like a surge, because like once you start to see like viruses and a lot of like the wastewater, like coming down from toilets and things like that, right? That kind of indicates, that gives you like a snapshot in time of like the viremia in the water samples, right? And viremia is a medical term, just meaning, like presence of virus and like, like a fluid or solution or something like that. And, like, so when a person is viremic, for instance, they have, they're releasing viruses. So yeah, so I mean, that's one way. Is it the best? No, I'd still be in favor of, like a bigger, like a more coordinated, like testing regime, the way that, say, the NHS is doing in Britain. But, like, you have to work with the tools that you have, not the ones that you want, while being mindful of the fact that the tools that you want, you should advocate for them, and in terms of public policy and whatnot.
Dr. Hines, are you on? We'd love to hear from Marilyn.
Oh, I'm here. I was just letting Dr. Walks do his thing. There are a couple questions in the chat that are specific to Dr. Despani about your bout with COVID, and they're about whether or not you were taking any supplements, or if your vitamin D level, and where you're getting a lot of sun exposure, those kinds of things. Do you have anything that you wish to share on those topics, either personally or in general?
That's a very good question. With returns to the vitamin D levels, yeah, I know you're supposed to have a certain amount, of IU international units, I believe, is the units. I actually don't know. I mean, I do eat lots of Greek yogurt, so that's my main source of vitamin D. So there's that. In terms of supplements and things like that, I don't necessarily take supplements, because I actually have like a pre-existing medical condition. So if I take something, I have to be mindful like check with my healthcare provider beforehand, right? Because I'm taking warfarin, which basically was rat poison that was repurposed to be used to help people on anticoagulants. So yeah, so I mean, it's a very narrow therapeutic index drug, meaning that you take too much of it, you can bleed out. You take too little of it, you'll have a stroke. So have to be very mindful. But I will share that like one needs to be mindful of like their like healthy eating, right? Because the reality is that one thing that you see in like, especially in minority communities, is the fact that many minority communities are what are known as food deserts, where they don't have access to like healthy quality foods and whatnot. And like that might actually aggravate these pre-existing conditions that like many in the minority communities have, right? I mean, just this idea that it's like, why are Blacks getting like disproportionately like hit, and also like Hispanics with like all of these, like the brunt of the SARS coronavirus 2 infections and deaths. And again, it's not having, like this easy and regular access to very healthy foods. And some things that I do like eat like that as a part of my normal daily like diet and routine are things that, again, help, keep your body, like a great state. Case in point, a prior program I mentioned, right, that a person should be looking at foods that are high in antioxidants, most specifically anthocyanins. Anthocyanins are a group of polyphenols that actually, like they're identified by the fact that they're in, they have high, I guess, not only antioxidant profile, but then the reality is that they can be identified by their color, right? They're usually red, they're blue, or they're purple, right? And that can be like in purple yams or black rice or red onions and things like that. And like that is like a color indicator that's provided by nature to tell you like, yeah, this is kind of good for you, so you should eat it, or blueberries, et cetera, et cetera. And then there are other things too. Like, I mean, you guys often see me sipping on my like big green cup. And the reason why is because that cup actually has, it holds about like 1,500 milliliters, which is 1.5 liters. And that's like of white tea. And like white tea contains, again, these polyphenols and whatnot. So these are things that are healthy for you, and you eat them or drink them or imbibe them every day. And the reality is that it's like compounding, right? Just like you can compound a bank account, you can also compound the health benefits that come from like these like biomolecules. Because the whole thing is that if you really think about like, eating healthy as a habit, as well as leveraging like biology to your benefit, that is actually what leads to people being able to combat, these diseases and whatnot. Because one needs to consider exercise, diet, and good sleep, and so forth and so on, right? It's a holistic regimen. It's not just one thing, like, oh, now that I've gotten infected, now I'm going to start, treating my body well. No, you have to treat your body well all the time. Otherwise, you won't be prepared when the fight comes.
Excellent point. The other question that I had was also, it's not even a question. It's just, can we explicitly have a conversation around any concerns that people might have about, can you get too many vaccines? Because if we're moving towards a space where every 6 months we might be having this conversation, it's a natural question. Like, is there a limit? Like, is 4 going to be a problem? Is 5 going to be a problem? Especially since we started out thinking that it was just going to be the 2, and now we're on the 3, 4. Some people are already on their 5th and 6th shots already. So I think it's just something that needs to be addressed, because lots of people were apprehensive, in the first place, but they did it. And now we're moving into a space where it might be indefinite. So
in conjunction with that question, could you comment, if you would, on, I think it's slide 8, 9, and 10. I think it's relevant to what Dr. Hines is speaking about, but it's more in techno speak. Maybe you can make it plain about neutralizing antibodies. I think that's inherent in the question that Dr. Hines was presenting. Simon, can you find this? It's labeled new article or something.
Are you saying, Dr. Maxey, that we were so excited to have Dr. Despani that we just ran past the slides and went straight from 1 to 8?
No. I just, what she's talking about, it fits with what we want him to answer. So this referred from the New England Journal, but it is not vouched for by them, but it had some thoughts in there that I thought Dr. Despani could better explain than I could. And it's a series, 3 slides, this one and 2 others.
So, okay, so yeah, with regards to this, what it's saying is that it won't be able to neutralize. Neutralize basically means that you have an antibody that actually like binds like Velcro to like the virus or the variant, and like can just immediately like like a one shot, it's done. The reason why that only happens according to the verbiage and syntax here, only occasionally with Omicron, is again because Omicron has undergone like all of these point mutations and whatnot. If I recall correctly, Omicron has had the most point mutations out of any of the variants, right? It has over 50 point mutations, and I believe that's only in the spike protein. So again, it's changed up, it's disguised, and it's cloaked itself to the point where it's it's more difficult for your immune system to recognize. So instead of being Lord Vader from Star Wars episodes 4 through 6 and 3, it looks now more like, I don't know, Darth Maul from episode 1, or even Emperor Palpatine, right? You don't really realize how bad he is until you get to episode 3, but he was a good guy and a senator and so forth and so on in episodes 1 and 2.
There's two subsequent follow-up slides on this. If you go to the next 2 slides.
So Dr. Maxey, before we go to the next slide, I went to public school, right? So what I'm seeing on this slide is just because you got sick with coronavirus doesn't mean that you're protected from getting sick with coronavirus again. I've had people tell me, I don't need to get vaccinated. I already had COVID. And what this slide, I think, is trying to help me understand is that just because you've had COVID doesn't mean you shouldn't go out and get vaccinated. Is that a fair way to say it?
Yeah, that's a fair way to say it, because the whole thing is that there's a saying in military tactics and strategy is that the enemy always has a veto or like a plan or point to make on a map, right? So the whole thing is that as Mr. Putin learned the hard way, right? Just because you say I'm gonna devour this country and whatnot, like that, nobody's gonna fight back. That's absurd prima facie. It doesn't accord with human instinct or human nature. And it's the same thing too with viruses and whatnot. Just because you have like a vaccine that's cute, that's pretty to the virus, but the virus is always trying to evolve, right? It's about survival.
Which is getting back kind of to the question I was asking you going forward. I mean, I'm not complaining. I'm happy that I have taken the measures I have taken. They have held me well, and I have, knock on wood, stayed well. But eventually, I'm ready to do some other things. And so if they say I need a second booster, I'll trot on over to Publix and get that second booster, for sure. But I don't take it for granted, and I'm putting out there that I don't think anybody should take for granted that, and you certainly are living proof of it from January, that even if you do everything that they tell you to do, you still have to be careful, because this stuff is still going to be around. It may not be at a higher level, but it's still going to be around. And for me, the important takeaway is we are going to have to maintain vigilance. There's no such thing as I am free. We are not going to be free.
And I think what Dr. Walk said is so important. Somebody said, well, I took the vaccine. I know somebody took the vaccine and still got infected. Well, this is a clear thing. The vaccine is not necessarily protecting you from getting infected. It's controlling the degree to which you get sick after being infected, the degree to which you get hospitalized, and hopefully doesn't allow you the greater chance of dying. But I'd like his comment on this series of 3 slides. There's 2 more, and I think we'll get to some of the things Dr. Hines was saying.
Yeah, it's the same thing too. The Omicron has changed so much that the levels of neutralizing antibodies is low relative to the other variants, and that's kind of why we like went ahead with this third booster campaign. And then secondly, yes.
This brings up that hybrid immunity.
Right. So hybrid immunity basically means that a person who has gotten vaccinated and also gotten infected, they tend to have the most robust and long-lasting immune response. The reason why is, again, to go back to that paparazzi analogy, that you have 360 or 365, 360 degree view of like some, celebrity or something, whether it's, I don't know, the guy from Good Times in the 1970s or Justin Bieber today, right? You just have that like kaleidoscopic, like response, because it's able to look at all the different bits of the variant that it's got its hands on. Whereas whenever you're getting the vaccination from, say, like recombinant protein vaccine, like what Novavax has, or mRNA, where the mRNA vaccines are actually produced in situ, which means your body actually like manufactures it itself. Like you're only producing against one aspect, that's spike protein, whereas you get those nucleocapsids and matrix proteins and all of the other good stuff that comes from actual SARS coronavirus too, like in your body.
And can you put that third one up?
Yeah, so this is kind of what I was warning about earlier, about the immune escape. Like when I would show all of those little cute images of how like alpha differ from delta, potentially differ from Omicron. It was just that again, it's immune escape, because the more, it shifts and changes, the more difficult it becomes for your body to recognize it. Yes, yeah, and I mean it's the same thing too. I mean, you still need to get protected. And then just so you know, we actually don't know what the rates are of getting long COVID. Like for instance, nobody can pull out a little graph or a map and say, oh yeah, you're less likely to get like long COVID if you have Omicron versus Delta and whatnot. No, we don't have the data to say that. So that's always like a risk that you run. And yeah, having cognitive loss, no matter how great or small, is not something good that I would think. And then actually to point to something that I had actually had like a brief discussion with Dr. Steiner on before, one thing that's kind of confused people is like they're kind of wondering like, oh, where did this Omicron variant come from? Because all of the phylogenetic, aka family tree, viral family tree studies that have been done have kind of like been confused, because with Omicron, like if you're looking at like a family map or whatever, you'd see like, alpha is here, like delta is here, and then all of a sudden like Omicron like is all the way over here. So that's thrown like virologists and geneticists for a loop. And we actually don't know how that happened, but there are three theories. One theory, the one that I have often championed for, especially for like the alpha and delta and whatnot, and like it's actually been validated for alpha and delta, is that you have someone who actually they were immunodeficient for whatever reason, and because of that, the virus basically used their body as a training ground to evolve all of these mutations and become worse. The second is that it could have been a recombinant, like a zoonosis. A zoonosis is basically when you have like an animal like transmits something to a human, or a human transmits something to an animal, and then the virus is trying to like reconfigure itself based off of like having all of this interaction within different hosts. And that's another like pathway. Or the third and the most parsimonious, aka the most like conservative theory, is that it basically was that our viral surveillance systems were just so like lackluster and poor that's why we had not like realized or identified Omicron until now. Which again, that ties back to a mantra that I'd used in one of the earlier programs, is that until everyone is safe, no one is safe.
Excellent. Dr. Hines, does that address part of your question about too many vaccines?
Yes. Thank you. There's a question in the chat around, and let's see, it says, there's updated information on COVID-19 deaths by race and ethnicity, and which state that, for example, 1 in 303 Black Americans have died from COVID, 1 in 319 whites have died from COVID, 1 in 394 Latinos have died, and 1 in 641 Asians have died from COVID. Does anyone know why COVID deaths have been so low in Asians in the US? Recognizing that the term Asians does not address cultural heterogeneity. And is there anything that they're doing differently? Is it income, diet, exercise, et cetera? And then I will also kind of piggyback on that question, because there's also been recent talk, and there were some articles in the Times around how the continent of Africa seems to have been spared the ravages of COVID. Is there anything? And then there's questions around what's going on with that. Is it just a lack of data issue, or is there really something different taking place? So just thoughts on those things.
I think for the Asian American thing, that's too broad. Like, and that's one of the reasons why, and just so you guys know, like, my unequivocal stance on this as a scientist, right? The whole idea of race and ethnicity are basically nonsensical, because everybody is like, has some, genetic, variants in single nucleotide polymorphism that come from everybody. So the idea of like Black, white, Asian is just nonsensical. And then secondly, as was pointed out by Dr. Hines, right? Like, okay, so you have to figure that it's, like East Asian Americans, Indian Americans, and then like Southeast Asian Americans like Hmong and Filipino, aka Pinoy Americans and whatnot. It's nonsensical, right? It's, at least speaking, from a biological and genetic perspective, it's nonsensical to try to lump, all of those in to what is ultimately like a sociological issue. Because again, race is not real, but racism is real. So that's more, again, in the realm of sociology. So, I mean, I don't think that you can actually get anything out of that from that type of stratification, other than like, maybe you might want to look at like how they're like exercising, or like what behavioral factors they're doing, but I don't think that you can draw anything, biological or whatnot from there. And then with regards to the data regarding like Africans being at a lower like rate of COVID infections and so forth and so on, are like bouncing back quickly. That may like have something to do with the fact that if you look at it from a demographic perspective, Africa is a continent with many nations that their average age is much younger than you would find in like a developed country like any European nation or the United States. So the fact of the matter is, we know that those who are younger tend to fare better when they get infected with COVID, and that could very well be that in that case at play. But again, that's a hypothesis. I'm not saying that definitively. And secondly, it's that also is a good, I guess, portender of the fact that Africa and its various nations will actually become like a lead driver of like all of this innovation and whatnot later on. It's actually proposed that by the 2100, Africa will be the driver of demographic growth and whatnot. But I mean, I think that could be one hypothesis, but I don't know like if that's definitive without more data.
Dr. Spanny, one anecdotal observation: when I've gone to major Asian countries, China, mainland China, Hong Kong, they typically tend to wear masks anyway, whether it's for the environment, the smoke, the whatnot. But it's almost like it's not an offense to them like it is to certain groups.
Right. And this is something we already talked on one prior program. Like a lot of it is like me, like reiterating, kind of like providing like a 30th anniversary edition of like all the stuff that I said beforehand, right? Like again, right, I remember I said that it really depends upon behavioral factors. mask wearing is behavioral. It's not genetic. It's not, immunological and things like that. I mean, it's just common sense. And like, if people can't, realize that, oh, putting a barrier actually like can protect me from getting variants versus putting my naked nose, like, up to a variant, like, behavioral, right? And again, the reason why that's a sociocultural factor is, again, like, East Asia was hit hard by SARS coronavirus 1, which many people don't seem to remember. Like, they're like, oh, SARS coronavirus 2, like Terminator 2, but they don't ever, I like Terminator 1, but most people are like, oh yeah, like, whatever happened to SARS coronavirus 1? Yeah, I remember it, but again, I'm a virus nut. So yeah, people need to be mindful of that. And then of course, you also have to factor in other environmental aspects like the high smog levels and the People's Republic of China, et cetera, et cetera. So, but again, yeah, if you're looking at a holistic explanation, yeah, you include the sociocultural and, like biocultural anthropology. But if you're talking about in terms of just genetics or, virology and whatnot, it's, if you're not looking at the, syndemic model, then, it's hard to draw any conclusions.
Well, we certainly have enjoyed you and hope you can stick around a bit. I know Dr. Nabert wants to speak a bit about what our federal government is doing to contribute to this confusion and to make the problem worse. Dr. Nabert?
Thank you. Did you not want me to share the data slides?
Sure.
Okay, so Simon, can we start there? We'll do that very quickly. I have, and others on this program, the other co-moderators, we have all at one point or another expressed some concern or the need for level setting what this data is really telling us. And it is getting to be even more of an issue as time goes on. And the next slide, please. And the biggest reason for that is the source of the data. And, it would be lovely if we lived in a country where every city had every health department have all cases reported to them like that. We have an analogy. If you are a clinician and you diagnose somebody with syphilis or gonorrhea or any number of sexually transmitted diseases, you are supposed to report that to the health department. But we don't have that process. And you can imagine that's not a foolproof program. And we don't even have any semblance of that around COVID-19. And then, so the source of information that is reflected in these statistics every day on the CDC website are subject to the source of the data, which is different depending on where the information is coming from. Then on top of that, it is influenced now by, at the beginning of the pandemic, there was more reliance on public health departments. And so there was a little bit more inclusiveness of incidence and prevalence. But now we are at a point where you don't have to go to the health department to get a test. And you certainly are under no obligation to report the test. So what this data that I'm getting ready to present is really a snapshot of what the CDC has, and they would never claim that it is a representation of the whole story. So having, again, emphasized the limitations of the data, we still are not in a great place. Here we are, March 2022, and we're fast approaching 80 million cases since the beginning of this pandemic, of which, of the ones that we know about, 12.3% were African-American. And we all know that this is not all of the cases. Even more limited in representation of the actual picture is the next statistic, new cases, and in a minute, the daily deaths, because that's not really based on specific reported cases, they do a mathematical extrapolation based on the differences in the numbers from the previous days. But given that limitation, let me say that this is relatively good news and that it's fewer than we have been having, but it's still 30,000 new cases. So that's nothing to sneeze at. Total deaths since the beginning is that we know about that have been appropriately attributed to COVID. Let me put all of those caveats out there. 974,000 people have succumbed to COVID. And of the known number, 13.6% were African Americans. And this daily death is an extrapolated number of 762. Next slide, please. Again, this is a little bit better than the case and death reports because more or less reliably, vaccine doses do get reported. There may be delays in getting the report and accuracy and all of that, but this may be a little bit better than the other information. So as of yesterday, there have been 217.4 million Americans, or 65.5% of the total US population that has received at least the initial series. You know, as a pediatrician, we talk about primary series and secondary series of the first series. And of those individuals, 10.1% were fully vaccinated. Again, the data is really wonky when it comes to booster numbers, but as best as they can report, 44.7% of the US population has received boosters. Next slide, please. Now, I alluded to this issue of home testing, and this is a hot off the press report on the CDC website that if you're really interested in all of this, you might want to take some time and read. And the Simon is going to put this last 3 lines in the chat because that's the URL link to the actual report. Next slide, please. But those authors have been looking at the use of home tests since they basically became available through March, the beginning of March. And not surprisingly, what they found was that the use peaked in January of this year when we were dealing with the Omicron surge. Now, what I found very interesting was 2 things. Why did people get tested and who got tested? So the why, now there are many more reasons than these 3, but the majority of the reasons fall into these 3 categories in descending order. Risk assessment, i.e. somebody was concerned about whether or not they had been exposed or they had symptoms and they wanted to find out if they had COVID. So that was the major driver for getting the home test done. Mandatory testing contributed, i.e. you had to have a test result before you could go back to work or go to school or go to the concert or whatever it is you were trying to do. And third was travel. And it was a very small number, but it was the third. And, you know, that's because travel has been fairly restricted. So those were the main reasons people were trying to get their home test done. But again, remember, it peaked in use in January and has been going downhill ever since. So even though there were those drivers before making people test at home, they don't seem to be that worried about it anymore. And as these mandatory testing result requirements start to fall away, you can be sure there'll be even less. And then in a minute, I'm going to tell you another reason why they're going to be less. That's coming real soon. So who were the users of the at-home test? Whites were 2 times as likely as African Americans to do at-home tests. Surprise, surprise. And But this is what I thought was kind of interesting. Adults who were 30 to 39 years of age were more likely than the 18 to 29-year-olds and the 75 and older. So I thought that this was a very interesting study, and I wanted to bring it to your attention. This is intellectual excitement. Next thing I want to talk about is advocacy rage. Now, I have to say, I just stopped this weekend. I've been attending an advocacy conference, so I'm a little fired up. But aside from that, next slide, please. I just told you all of that. The other thing is household income. People who had household incomes of 150,000 or more were much more likely to do the at-home test than those who earn 50 to 75,000, which is, believe it or not, considered the median household income. I think that's a little high, but anyway, that's the official median household income. And people who had postgraduate degrees were much more likely, as you can see by the numbers I provided, than those with high school degrees to get the at-home test. But I've been thinking this whole last 2 weeks that there's a lot of stuff going on that we're not hearing about because there's so much, and deservedly so, attention being paid to the Ukraine situation. And I've been thinking to myself, what else is going on a number of subjects? And then lo and behold, Thursday, I think it was, next slide, please. I saw this article and I said, whoa, I was wondering how that, well, I may be about to say something politically incorrect, so I won't say that. But I was wondering what was going on in Congress because you weren't hearing anything. My assumption was nothing was going on except the hearing on Judge Jackson. But apparently there has been some appropriation discussions going on, and Congress has sat on a 22, and I'm gotta move my bar here, a $22.5 billion emergency funding request that the president sent to Congress. And you all are saying, well, what's new? They are always not doing what he wants. But we need to pay attention to this. So this is where my advocacy is coming out. The fact that they have not voted this appropriation has some very serious consequences that will impact each and every one of us. And at the bottom of this slide, and I asked Simon to put this one in the chat too. This is a link to the White House fact sheet on this matter. As a direct result of their not voting this money, health providers who have been providing testing and treatments of uninsured individuals will no longer be able to submit claims for payment as of March 22nd. That means they will no longer get paid for taking care of uninsured.
When is March 22nd?
It was this past week. Provider payments for claims for vaccination services will no longer be accepted after April 5th. Federal government is going to reduce its monoclonal antibody shipments, which were inadequate in the first place, but they're going to cut them by 30% because they don't have the money to buy it. Purchases of additional doses of sotrovimab, which is an IV, and the oral antivirals, and I'm not going to even try to murder their names, will be suspended. And support for the adequate surveillance of emerging variants is going to be cut. Now, next slide, please. There were planned purchases of Evusheld for March 31st, which is this coming week, which was to be made available for immunocompromised individuals. that is not going to happen. And just so you know, a course of treatment for this is between $500 and $700. The US government, if you recall, back in December, I think it was, announced that they were going to ramp up their financial support of in-home tests, which they did. However, that is going to end in June, which is what I was alluding to when we were talking about the in-home tests, what may contribute to a decrease in their use, because they're not going to be available again. So, you might want to stock up on a few. Then support for, this is the basis of my question to Dr. Despani. Support for adequate surveillance of emerging variants by our government is going to be cut. Now, some would say it wasn't the greatest in the world in the first place, and we're getting ready to cut it, which means that if we're not using appropriate public health measures, we may again find ourselves flat-footed if there is another, or I should say when there is another surge. And then finally, and I started to make this first, as Dr. Despani said, one of the last things he said was, until we get rid of it in everybody, we will all be subject to getting it. And we're getting ready, based on the lack of this appropriation, to reduce our participation, which means supply, of global vaccination and COVID-19 treatment efforts worldwide. So there is every reason for all of us to be very concerned about the games going on in Congress. And if you understand and are as concerned as I am, I would encourage you to reach out to your congressional people and let them know how you feel.
This was extremely important, Dr. Nabert, and combined with what Dr. Despani showed us before, that even with the current situation, Black people were more likely to be sick and hospitalized, et cetera, and they're going to cut even the support that we had for testing and treatment then. This almost, well, I guess I have to learn from the new Supreme Court Justice to be, we can't really call it what it is. Ordinarily, I would say it's racist, but we can't say that, Dr. Walks. I know you'll get me, but we do have to start speaking up more about things that directly affect us and our families and our loved ones, and not just sit back and let people do or not do things that affect us and we just stay quiet. We have to speak up about that. Are there any other notes in the chat?
Well, I did see a question, a follow-up question, and the fate of the Medicare payments is still being fought out. It's caught up in this as well.
So it's interesting that physician payments are going down. Now, we already know that the few Black physicians that are in private practice in the country make significantly less than do the other physicians. And we know that the burden of the physicians providing care in our communities is considerably higher. So this is going to have a double whammy effect of an economic effect. And if they take away the care of uninsured people, of which we have a high number, it's just going to be a multiplying effect. So we're not supposed to be political, at least not in the terms of Democrat and Republican, but in the mind of public health. What do we need to do in addition to what Dr. Nabert Stevens is talking about, Dr. Walks? This is your bailiwick in public health.
So Dr. Maxey, I'm going to hold my comment for a moment because Reverend Pointer has raised his hand and has a comment make. So if we could get Reverend Pointer unmuted so we can hear his comment.
Has he got his bridge back in the background?
He does have the Golden Gate Bridge in the background, and I know he's nowhere near the Golden Gate Bridge, so I don't know. I struggle with it all the time, but go ahead, Reverend Pointer.
Well, you know, some things are aspirational. You don't need to struggle.
The struggle is real. Yes, sir.
And the actual is only part of what we live with. The aspirational is what we should all be aiming for. But I wanted to make sure to understand that it's not accurate to call it racist, but it is accurate to say that these things are built on a system that is perpetuated and enabled by 4 centuries of race supremacy and race supremacy policy. And there is the absolute rejection of the fact that race is a social construct. It's not a biological imperative in any way. There is one race on the entire planet, and that is the human race. So I think it's important for us to point out that people who have the phenotypical qualities that you and I possess commonly tend to be those who are marginalized, discriminated against, and blockaded from treatments that would keep them alive, keep their lives meaningful, and keep them in the kind of physical condition so that they could enjoy life. It's not racism, but it is the construct of these kinds of systemic policies that have existed over the last 4 centuries, continue to be erected, as you heard Dr. Neighbor Stevens talking about. Because the other thing we need to be clearly understanding is the 535 members of Congress have premium health insurance that you and I pay for. And they're not interested in extending even basic health insurance to the average American who lives in an undeveloped community, no matter whether it's in the rural, ex-urban communities or if it's in the centers of our urban cities. And I think it's critically important for us to know that. And that's why it's important for us to also hear very clearly what Dr. Neighbor always tells us. This is about common sense and the exercise of common sense. And while I know my grandmother was right when she said that common sense is not common, those of us who have it need to use it.
Well, thank you, Reverend Pointer. Let me comment on the public health aspects of this and on the political aspects of this, and let me toss in what my brother and leader, Dr. Despani, said about the whole biological basis of race being at best inaccurate. And I'm going to take that with what Reverend Pointer said about, reality and aspiration, and reality is only part of it. Let me put all of that together and say this. We have to be aware. Dr. Neighbor Stevens is exactly right. We have to be aware of what's going on around us, because even though race may not be a valid biological construct, it is an apparent and really obvious sociological construct. And we are caught up in so many things. People treat us differently because of what they see when they look at us. And we have to know what's happening in our communities. We have to understand what it means, even if it's not the first story on the nightly news with Lester Holt, or it's not at the top of the Twitter feed or wherever you go for news. We need to dig a little bit deeper and understand how these things impact us. So it is not at all politically inappropriate or racially insensitive to say that we should look carefully at what's happening in our government, what's happening in Congress, what's happening in our local state legislatures, what's happening in our local mayor's office or our county executive or any of those places, and understand what they're voting on, where the money is going, where the attention's going, because it matters. It matters to us when we're trying to keep ourselves and our families safe. A lot of those things impact. Dr. Despani mentioned earlier today about food deserts and where food is available. All of those things come into play. So I know it can be just oppressive. It's like a summer day when it's 100 and something degrees and it's just oppressive. Our situations in many of our communities can be just oppressive. You don't want to think about it. You don't want to hear another bad news story. At the same time, proactively paying attention, making that phone call, knowing who your supervisor is for your county, knowing who's in your state legislature, it makes good common sense for us to know what those people are doing, if for no other reason that we know how to vote the next time an election rolls around. If you can't reach somebody that's elected to represent you, if they're voting for things or putting things in place that aren't serving you, it makes sense to know that. So my comment from the public health perspective, Dr. Maxey, is that there's no way I could overstate how important it is. It's massively, ginormously important that we understand what's going on in our communities and in our country as it relates to public health. If I need an oral pill or medicine of some kind for COVID, and I was not paying attention when they cut off all of the funds for the COVID medications, that's a problem. That's on me. I need to know about that. So, that's the first 10 minutes of my 3-hour lecture on how important it is to know what's going on around you.
And I want to comment, and all the moderators feel free to jump in. And we haven't heard from Dr. Wilbert today either. But I was in a meeting with a company, I won't mention their name, and two basically smart but not particularly educated people of the other persuasion were interviewing me. And this one young man said, "Do you mean that you don't have the competence to write a questionnaire?" And the word competence. Now I'm sitting in front of guys with, if they have a BS degree, that's fine, but I'm there with an MD and a PhD, and they're going to question my competence. And I'm reminded in watching this, our new Supreme Court justice, who was obviously more qualified than any other justice currently on the court, and probably all 115 that have been there before. And they belittled what she was. And when Dr. Hood spoke some months ago, and others have spoken about the things that tend to beat us down because of lack of respect and whatnot. Dr. Walks and Dr. Neighbor and Dr. Hines, how does this play into the way we protect ourselves going forward? I'm just concerned that we have so many competent, accomplished people in our professional corps, but yet and still, if we didn't have our own organizations like the NMA and the AMA and the Student National Medical Association, where would we be? I'm concerned about that. And I don't want to say everything is racist, but as Dr. Pointer said, it has a component, and it bothers me immensely. And I know Ketanji could not afford, if she wanted to be confirmed, to really tell them to do what they should do. But I'd like a few comments on that.
Ladies first.
So I'll say this. So during the confirmation hearings, so when Judge Jackson was being questioned by Senator Cruz, and Senator Cruz asked her a question about, are you saying that babies are racist? And then she pauses, right? And she pauses, she sighs, And then she pauses, and then she paused for 7 seconds. And then went on to give a very poised response. And what I think all of us as people of color know what's in that pause. It's that space where you decide, right? Am I gonna risk it all to let this person have it, right? To tell you what I really think of you. And one of the things that I think that we can all do to protect ourselves in the context of the world that we live in is sometimes take advantage of a moment to pause and ask yourself, is the thing that I'm about to do, whether it's wear a mask, go off on somebody, you know, how I choose to say the next words that come out of my mouth, or the email that I send or don't send in the way that it is currently written or whatever, is to pause and just think for a second before you take that next step.
So Dr. Hines, I would put what you just said in the category of strategy and tactics. But I would like to go down the path of practicality. My listening, I didn't get to hear a lot of it, but the bits and pieces of the hearing that I did hear were examples of how she knew more about the law than the majority of the people in that room. And yet they had the audacity, the arrogance to challenge her. And my thought was, how often, I was just in my little life, have I been assumed to be the ward clerk or the secretary? Or I have gone into a store and picked out something that perhaps was expensive. And although it wasn't verbalized, the look was, what are you doing touching that? And we all can think of other examples of how we have had psychological assaults on our Blackness. We are going to have to continue the fight that started when the first African was captured and put on the very first boat. And we've been fighting ever since. And we will continue to have to fight until we have victory. And we will have to fight in every way that we need to. That's my response.
Okay, so I'm going to put a smile on my face and tell you why what Dr. Hines was watching and what Dr. Neighbor Stevens was watching and why what Dr. Maxey was watching inspired me. Because what I saw was clear evidence that the most powerful people are still trying to keep us down, and yet still we rise. That's what I saw. I saw I saw a Black woman named Ketanji get up in front of all of those people and prevail. And I think it's important for us to do exactly what Dr. Hines said to do in terms of a tactic and a strategy. And I think it's incredibly important for us at the same time to understand what Dr. Neighbor Stevens is telling us about how far back the struggle goes and the struggle is real. And then to celebrate that in the middle of all of that, there's a sister named Ketanji that can get up with the appropriate strategy and tactics and persevere and triumph in the middle of that. And I think every African-American or other person, anybody who believes in fairness and who looks at accomplishment and who looks at what is the end game, what are we trying to get to, Anybody who sees that in the middle of the angst about what they did has to please recognize the triumph, recognize that, and yet still we rise. In the middle of whatever they're trying to do, we can name our kids Ketanji and Malcolm, and they can stand up in front of the powers of this country and every other place on this planet and pray their way through and persevere their way through. That's what I got, Dr. Maxey. So I'm mad, I'm angry, and I'm not pausing as often as I should, but I'm celebrating all the way that Sister Ketanji got where she got.
Well, thank you, Dr. Walk. So we're near the end of our time. First of all, I really appreciate Dr. Despani being here with us with his level of knowledge. And I'm always amazed that, and I don't mean this in a pejorative way, but he's a very young 31, are you 32 even yet, man with a PhD, a pharmacy degree.
And he's so articulate.
And he speaks at the highest level. You should be speaking instead of this guy, who's the guy that's always on TV, Dr. from NIH. So you're a jewel, sir, and we'd love to have you have some final words for today, but we appreciate you and elevate you.
Final words, just going back to the same thing. Yeah, like I always say, right, that race is not real, but racism is real. And I mean, it's just inbuilt, like, I guess, bias or heuristic that needs to be overcome. So the reality is that one, become the change you wish to see. That's an imperative for everyone within the minority community that has not yet reached the zenith of its power, but probably will by 2042 once demographics may or may not change. Secondly, I want to reiterate that the FDA will likely give approval sometime next week, probably Tuesday, but may even be by Friday. We'll probably give approval for a second booster that can be utilized in those 50 or older. And then thirdly, I just wanted to loop back to something that had been shown, that sotrovimab, one of the drugs that's not being, it's a monoclonal antibody drug. It's not being, funded and whatnot. That's probably for the best in this case, because a New England Journal of Medicine article detailed that sotrovimab basically is not really working against Omicron variant infections, and that's actually causing monoclonal antibody resistant, because the Omicron is so wily and able to, like shape shift and so forth and so on. So those are the three important things. Hope you guys have a wonderful Sunday.
And thank you. Before we go to Buffalo, New York for our final thing, who's that waving their hand? Is that Dr. Jordan?
Dr. Sherrod has her hand.
Dr. Sherrod? Can you unmute Dr. Sherrod for a brief comment?
Yes, thank you, Dr. Maxey. I just wanted to comment on the comments that were made concerning the judge, Ketanji Brown Jackson.
Yes.
There is a write-up actually in the Washington Post that I would like to refer people to, which summarizes exactly what she was doing, which was actually just expounded on by Dr. Hines and Dr. Neighbors-Stevens. But she was also mitigating that stereotype of the angry Black woman. And she did it very elegantly. And I agree, the pause, very, very important, because you can take a deep breath, you can center yourself, and then you can come from within, from your God self. So I think she handled it just elegantly, and we know she's highly overqualified. But the other interesting thing that has come out, and you didn't really mention that, Dr. Maxey, is this thing with the wife of our current African-American Supreme Court Justice, who had sent those emails concerning the January 6th uprising. That's a whole nother topic.
That's
Well,
a whole
thank you,
nother
Doc-
topic.
Thank you, Dr. Sherrod.
Yes.
So I'm going to violate a principle of trying to be out of here exactly an hour and a half and just invite a few of our advisory board members to make very brief comments. And before we go to Pastor Pointer, Dr. Steiner, Dr. Gibson, other members of our advisory, Dr. Steiner.
Sure. Thank you, Dr. Maxey, and thank you, Dr. Despani. First, I think I'm chairman of your fan club, and I think I speak for lots of people thanking you for your presentation. And as far as Judge Jackson and all, I just look at her as her accomplishments and who she is. And my feeling is, you know, if you just don't look at color and you look at the person and you look at the hearing and you forget that it's Ted Cruz and you just listen to what they say, this is probably the first normal, brilliant person that has been up there for the nomination. She's normal. She's like us, you know, she's just a normal person. And I think she's going to be great. And I think it was, I think Biden is to be commended for picking her because I didn't know who she was. And I really dug into it. And I think we got to be all proud of her. And that's just my 2 cents for today. Thanks for another great day, everybody.
Thank you. I like that description. It was so apropos, normal. So many.
She's absolutely normal. And you don't see that. I haven't seen it on any other nominee. So I felt like this is someone I could sit down with, have a cup of coffee and, you know, a beer or a sandwich. And, you know, this is someone who thinks like me. And that's what I think we want up there. So, okay, those are just my words. And I know I'm echoing a lot of people I spoke with about her. Okay.
Any other members of our advisory on?
Dr. Gibson's on.
Dr. Gibson?
One thing that we cannot afford to do ever is to let our guards down. Clearly, we've witnessed, even with our great Dr. Despani having been victimized by this virus, even despite best efforts. So best efforts even are not enough. So having said that, I have to say, we, as always, must rise.
Thank you. I'm going to call on our resident technical expert, Mr. Cooper in Miami. You care to make a quick comment?
You're getting me on the microphone for the first time, I think, in 2 years. Just echo a lot of what we always say. Common sense is not common, but if you have it, use it. I understand that people don't want to get the vaccine. So if you don't want to get the vaccine, put a mask on. You can't do neither. Pick one. Do both if you're really trying to help improve the situation. I was hesitant at first until I got some information from Dr. Despani. Once it made sense to me, I made the choice, and I decided also not to be selfish because it's not just about myself. I have my mother and my son to think about that I live with. I'm around strangers all day. I don't know how they carry themselves. So the least I could do to make sure the people that I care about are safe is to make sure that I'm as safe as possible so I don't put them at jeopardy. So.
Well said. Well said.
Thank you. Thank you. Well, I appreciate everybody. I'm presuming that all of our advisory had a chance if they wanted to make a comment. Coming up in the future, I've spoken with one of the executives associated with one of our historic leaders, Reverend Jesse Jackson, and he's agreed to be present on one of our shows coming up to speak. And I'd also like to re-ask Dr. Ivan Walks to contact a congressman in Maryland who had agreed to give us comments. And I think that's especially important that we look at the political aspects of this. So with that, unless there are some other comments by our moderators or anything in the chat we need to deal with, I'd like to go to one of the best parts of our program, who's probably buried in snow in Buffalo, New York, Pastor Pointer to take us out.
I love you, Randall. We got a dusting of less than an inch. It's like dealing with dandruff in Buffalo. A little bit of snow, nothing to concern ourselves with. I want to thank you all because you may not realize how critically important and valuable this Sunday afternoon colloquium is. It's so critically important. Thank you all. Let us then ask the Lord's blessing. Holy God, Jacob's God, the everlasting who existed in and of yourself without any need of assistance. The one who called world and worlds into being merely by your word. The one who is majestic, all knowing, all seeing, all powerful. God, all by yourself. Thank you. For yet another Sunday where you have allowed us to assemble ourselves, to build the bonds of family, to encourage each other, to lift each other, to give information that is useful. And then, oh God, we ask you to empower us, to leave this time of fellowship and of sharing and go out into the outer world, launch out into the deep and establish a line of communication and of love that encourages our brothers and sisters to do well, but also to be well. Thank you again for your servant, Jordan Despani, for his dutiful preparation, his attention to detail, his singular skill at taking the complex and making it common. Thank you that he doesn't count it robbery to hang out with us on a Sunday afternoon. As we go to our several places and about the busyness of our living, grant unto us your everlasting presence, your care and concern, and empower us, O God, that we may rescue your people from the calamities that assail them, from the evil that's all around them. And let us hear David when he said, I look into your countenance and find justice. We'll be careful, oh God, then to give your name the glory, honor, and praise. In Jesus' name, amen.
Amen.
So thank you, everybody, and thank you, Simon Cooper, for making this possible. And thanks to our co-moderators and to our guest, Dr. Despani. Everybody have a great afternoon.
Thanks again, Dr. Despani.